Good evening, everyone. My name is Rick. I don't even see all your faces. I only see like who this is in my face. But we are your entertainers for tonight, and we are very much looking forward to talking about psychosis and how racial biases affect the diagnosis of psychosis and treatment. And we are eager to learn from you guys as well, from all your experience, from all the work you are potentially going to do as a mental health advocate. I'm a PGY1, so I just started about a year ago by now, and I'm currently on the inpatient psychiatry unit here at Duke University. And my big passion is not only inpatient psychiatry, but also global mental health. And I've been working with governments in Ghana and Kenya on mental health policies for about 7 years now. And hand it off to Odessa.
Hey, thank you, Rick. Wow, that's like a big, sounds like big things you have been doing for many years. I don't have that great of an experience so far. I'm Odessa. I'm a third-year resident, so my experience is very limited. For past 3 years, I've been doing psychiatry. I am currently doing outpatient psychiatry. And I would say learning outpatient psychiatry has been a great experience because for the first 2 years, we do inpatient psychiatry and see more acute patients with psychosis. So it's kind of like, there are some of the things that we would be talking about today, especially the biases and the inequities. I think that, outpatient psychiatry really gives us more exposure to these areas and helps us understand them better. So thank you all for coming.
All right, so let's get started. One thing ahead of the presentation, it's going to be a little bit of a lecture, but more so we also want to hear from you guys, as I said before. And if you have any questions at any point, please feel free to just raise your hand, which I might not be able to see. So please just call me out on if you have a question, and you can also use the chat. So here you see our learning objectives. I don't want to read them to you. By now you might have read them already during the time we took for introduction, and let's just move on. And we just want to start, and so please unmute yourself if you want to participate with just asking you about the brain and what it does, and just some general brain anatomy. I know this is week 5, lectures are coming to an end, but we would just be interested in seeing if you guys can match the parts of the brain labeled from A to F with the functions of the brain labeled from 1 to 6, and obviously they're not in the right order. So please just unmute yourself, give us the color of the brain area you're going to talk about, and tell us about the function as well as the name.
You can also use chat if that is easier for you.
Sreya.
Yeah, the cerebellum is in purple towards the bottom.
Yep.
And I think it's involved in balance.
That's exactly right. One way of remembering it, I don't know if this is helpful or not, but some people say cerebalance instead of cerebellum. So that's one way. A good test to actually, to test the balance of someone is, I don't know if you were ever drunk and we're trying to work on a straight line, which is almost impossible. And guess what? The alcohol is affecting your cerebellum and it's affecting your balance. And this is why. All right, thank you. And that's right.
Yeah, I'll go next. So Occipital Lobe is the purple in the back.
Yep.
And that's for vision.
Okay. Here's another bad way to remembering it. Some people say Occipital Lobe, like seeing. Might be helpful or not, but now you know.
Also, Brandon says
yep.
Blue equals brainstem, which equals heartbeats, breathing, circulation.
That's exactly right. And if you cut your brainstem, basically you're dead because all the basic functions of your body stop working. And that's why And as I say, Chloe is also saying the yellow part is the frontal lobe. It's responsible for decision making. That's exactly right. It's actually one of the parts of the brain which distinguishes us the most from other mammals. And interestingly, like matures until we're 25 years of age. So I don't know what the average age is in this group, but I would assume that for some of you, this part of the brain is still developing. So keep it safe and healthy. I see we got the green part as the parietal lobe for touch and mathematics. And you're right, you switched it with the red part. So the green part, the naming is, it's the only one which is left, is the temporal lobe. And one way to remember its functions, if you look at your head, actually, the green part is right here above your ears. So the function is to hear. And also it's responsible for memory. Deep down there, you might have heard about the brain structure called hippocampus. And it's actually just, you know, beyond inside your brain, beyond the temporal lobe. And then the red part, as you rightly pointed out, is called the parietal lobe. And this one is responsible for touch and mathematics and these kind of things. So well done, guys, well done. First job done for tonight. Now the next question is, now that we know what the brain does when it is healthy, you know, how do we know that someone's brain is sick? And again, you can either use the chat, just raise your hand and just give us some buzzwords, like how do you know that someone's brain is sick? Oops, trying to find the chat function. All right, we got, yep, atrophy of neurons. That's right. How else? Well, sensory motor difficulties, yep. What else, guys? Conduct a neuro exam, yep. Chemical imbalance, altered mental status. Very good, very good. Few more. What are some other signs that someone's brain is sick? How do you know? What are the symptoms? Mental distress, yeah. Mental health symptoms, very good, Chase. But now we need to be more specific. What are some of the mental health symptoms you refer to? Hallucinations, yeah. Very on spot for tonight. Obsessive thoughts, actions, yeah. So I guess to cut a long story short, basically the functions we just talked about, right? Everything which goes well when our brain is healthy can go wrong when our brain is sick. So if your vision doesn't work or your occipital lobe doesn't work, you might not see at all. And that's the case sometimes if people have a stroke, or you might just see things which are not real or which other people cannot see. And then this is what we call hallucinations, right? The same with hearing. You might not hear things at all because you have a stroke, or you might hear things which are not real. And then again, this is what we call hallucinations. But then, also our brain is responsible for movement. So for some people, if their brain gets sick, they just have difficulties with moving, like Parkinson's disease patients, for example. Our brain is also responsible for emotion. So in some people, they just feel constantly sad, or they feel constantly happy, like too happy. And then they might have a condition we call depression or mania, or if they have both of these conditions, we call it bipolar disorder. But you're absolutely right. With all the examples you gave, you're super on spot. Now, let's talk briefly about psychosis. Again, that's the topic of tonight. What are some of the major symptoms of psychosis? We kind of think about psychosis in three different spectrums. On the one hand, we have positive symptoms, symptoms, if you look at the normal brain function, and then you look at let's say this is the brain function. Let me actually go to this slide. The brain function is in between here is considered to be normal. Now, everything above the normal brain function, everything you're adding to your normal brain function is considered to be a positive symptom because you're adding something, right? And so positive symptoms in this case can be either hallucinations, And we already talked about there are, hallucinations are kind of perceptions to a non-existing stimulus. Like people think they hear something and they think there's a voice, but there is no voice. People think they see something, but there is no stimulus which makes them see something, right? They can smell things, they can feel things, they can taste things, they can see, they can feel. So these are hallucinations. Another positive symptom, like something which you add to your normal brain function, is called delusion. And delusion is basically the idea that your perception of the world, your idea of the world, the reality, how you see the world, is distorted. And there are certain criteria which makes it a delusion. Patients have to tell you on their own. It's not objectively true in their cultural context. And also, if you start challenging patients on delusions, they would not give up their belief system. If you say, well, what you tell me doesn't sound right, they wouldn't agree with you. And they say, no, but I know this is true. Interestingly, delusions really are context dependent. Oftentimes, at least, there was a lot of research during the Cold War time, when there was a lot of conflict between the US and Russia. Interestingly, a lot of delusions were about the Russian, like here in America, were about the Russian people trying to spy on Americans, implanting like little machines and like trying to have like almost like paranoia, where the Russian people were coming after the American people, which was pretty much in the context of the Cold War times. Now that we have 2021, there's a lot of technology. A lot of people actually, don't have these like Cold War delusions anymore, but they have a lot of these ideas that, someone implanted like a robot or like a device in their brain, which like controls them. So delusions are context dependent and time dependent, which is particularly interesting because it's, you can also start asking yourself in communities you're going to serve, what kind of delusions might be more prevalent and why? And what do you do with delusions which have a strong religious content, right? Like what is still considered to be religion and what is like already a delusion? And that's a question we are not fully answering for you tonight, because if we were able to do it, we wouldn't practice. But one thing I want to say is like, one thing I always think about is delusions as, as soon as they are kind of like interfering with your ability to function, to take care of yourself, to have a job, to take care of a family, then, that's something we need to look into. And then the opposite of positive symptoms, as much as your brain can have things in addition to its normal baseline, sometimes, our brain just stops doing things which it is supposed to do. And this is what we call negative symptoms. And this can be poverty of speech and thought content. This can be poverty of affect. So where you are like down, feeling down all the time, like dysthymic, you just like stop having interest in things you used to like to do. You stop having friends, you're socially withdrawing, staying at home. You might lose your job, you might drop out of school, and these kind of things. And then the third category of symptoms of psychosis is what we call disorganization. Disorganization can be disorganized speech, where we basically, people tell you something and you're just like, wait a minute, what did you just tell me? I couldn't follow you. And you ask again, and it just doesn't make sense. And then another sign of psychosis is if people have disorganized symptoms such as catatonia, which is, it's not fully clear what catatonia is, but our understanding as of today is it is some form of brain slowing, like the brain function is slowed down. People get stuck in their movements. People get stuck in their thoughts. And it's very hard for them to express themselves, to eat, to participate in these kind of things. And these are the core symptoms of psychosis. Now, if you look at psychosis, generally there are like two big categories of psychosis. On the one hand, we have organic psychosis. And organic psychosis means we do find, if we do some exams, we do find reasons why someone might have psychosis, like these kind of symptoms we just talked about. These might be because people have autoimmune diseases. It might be because people have a brain disease, such as a brain tumor or a stroke or trauma. And this might also be because of drugs. And there's a lot of like research about, a lot of different drugs inducing psychosis, including LSD, cocaine, weed, cannabis. And interestingly, Some people smoke their whole life and will never get any psychotic disorder. Some people smoke once and they can get a psychotic disorder. What's really interesting is that some people actually convert from what we call organic psychosis into non-organic psychosis, which then is the category which you see on your left. Non-organic psychosis, meaning there's no longer, or there's never been an organic correlate in your body causing the psychotic disorder. And this is, for example, I think the well-known schizophrenia, which about 1% of the population has. Now, if we look at the reasons briefly why someone might be psychotic, we know it's an interaction between genes on your left, genetics, and the environment. And so this is what we call gene-environment interactions. And some events which can lead to psychosis are prenatal events, such as infections or drug use, even like upbringing, or like, if your mother is in a more urban environment, because it's causing a lot of stress, for example. Perinatal, like if you are a preterm baby, if you have a C-section or complication throughout the delivery process where you don't have a lot of oxygen, and then postnatal, like if you lose one of your parents, if you're like a foster kid eventually, trauma, any kind of trauma, emotional, physical, sexual abuse, or substances as the drugs we just talked about. Now, to understand some of the treatments for schizophrenia or for psychosis in general, we need to take one more step and need to understand how neurons communicate. Neurons being the brain cells, like the cells in our brain. And so the question is, how do they communicate? And here, you might have seen this before, either in high school or throughout your college experience or wherever. But you might remember that there's like a presynapsis on the left and there's a postsynapsis on the right. And now the big question is like, how do these two things communicate, right? There's a synaptic cleft here. And so the first thing which is happening is, well, there are two components, like one, and the presynapsis here, this is what we call neurotransmitter, like transmit to send a signal. And neuro is just like the brain, so to send a signal in the brain. And then on the postsynapsis, we have receptors. And in this case, you only see one neurotransmitter and one receptor. And it's like the key and the lock, like a lock or like a door, right? Where you basically, if you have a lock and you have a key, there's like only one key fitting in your lock, opening the door. And the same for the neurotransmitters. So the triangular neurotransmitters go into the shapes, like the receptors, which are also like shaped like triangles. And this is obviously a simplification, but you can think about this as a second neurotransmitter might be circular, and then the third one might be like a square. So there's like very, more or less specific interactions between the receptors and the neurotransmitters. So first, what happens is there's a signal coming, some kind of stimulus, which activates the presynapses. And what happens next is that as you can see here, the neurotransmitters are still in the presynapses. And once the signal hits them, they are released and they are binding at the postsynapses. And by doing this, they're activating the postsynapses and then transmitting the signal. Now, at some point, our brain needs to stop doing this. And what happens is that the neurotransmitters get just released from the receptors and are taken up again into the presynapses, as can be seen here. And this is the original state. And then there's no signal anymore. By the way, this is like one of the things about epilepsy, where the neurotransmitters would just continuously hit the receptors, and like many neurons at the same time. And by doing this, it's actually causing people to cease, to have seizures, because the brain is just overactivated. Now, how does this work in psychosis? And one of the main transmitters in psychosis is dopamine. Dopamine is responsible for the reward system. Dopamine is responsible for pleasure. Dopamine is also responsible for moving forward, movement. But dopamine is also implicated in psychosis. And the way it works, and this is what I just explained to you in more detail, is the neurotransmitters which are released, they bind to the receptors, and by doing so, there's a balanced flow. In schizophrenia and psychosis, we do have too many neurotransmitters. There's too much dopamine, as you can see here, highlighted, portrayed by the increased number of red dots. So there's a dopamine overabundance, which is basically, if you compare the arrow here with the arrows here, there's way more signaling happening. There's like, the neurons are too excited. There's an information overload, which can, for example, cause delusions, which can cause hallucinations. Remember the plus symptoms, like something is happening in addition to the normal brain function. And this is what we call acute psychosis. Now, let me ask you, what are some of the ways to decrease the dopamine? And this is not a trick question. There are like at least 5 ways how you can decrease the amount of dopamine in the synaptic cleft, or the amount of dopamine binding to the receptors. Like, tell me a few ways how you can reduce and decrease the dopamine concentration. Workout, okay. Someone's saying you can, degrade excess dopamine. Yeah. What else? And please, again, like, feel free to unmute yourself and just speak up. If you speak up and your answer is right, your dopamine will go up. You will feel pleasure from it. I promise.
Would deep breathing help?
Deep breathing?
Would that help?
It would help to calm you down. It would not necessarily change the dopamine concentration.
Okay.
But good idea. I mean, that's very important in psychiatry in general. If someone is very ramped up and anxious and agitated, deep breathing is always a great idea. So keep this in mind for sure. We have blocked dopamine receptors. Yep, that's right. That's right. Drinking green tea. Yeah. There are many ways to keep your brain healthy, right? Sleeping, drinking green tea, deep breathing, exercising, these kind of things. If you choose to pharmacologically alter the dopamine, like, there are at least 5 things you could do. On one hand, you can just, we can just think about, well, let's design a medication which decreases the production of dopamine. So at the end of the day, the pool of like available dopamine is just limited, right? That's one way of doing it. The second way of doing it is just like, well, we might have the regular amount of dopamine or even too much of dopamine, but if we can stop the release of dopamine from the presynapses into the synaptic cleft, then there wouldn't be like any dopamine to bind at the receptor. And in this case, well, there wouldn't be any overload. The other thing is, and I think someone said this, unfortunately, I don't see the name right now, but we can just also block the receptor where, okay, there's a lot of dopamine in the synaptic cleft, but it doesn't matter because it cannot actually bind to the receptor. So I think Ellen said this. The other way of doing it is to increase the reuptake. So yes, maybe it's binding, and yes, maybe it's an overstimulation, but if we increase the amount of dopamine being taken up and doing it faster, then the dopamine concentration in the synaptic cleft is faster. And the last one is we can, if the dopamine just stays in the synaptic cleft, well, are there ways how we can metabolize the dopamine so it stops overstimulating neurons? And one of the most common medications used in psychiatry is an antipsychotic. And an antipsychotic, most of the antipsychotics have different affinities for different receptors, but one of the most common ones is what we call a D2, like a dopamine 2, they're different dopamine receptors, but this is a dopamine receptor antagonist. And what it does is it blocks like some of the receptors which were previously occupied by dopamine. And by doing so, it reduces the amount of the signal, the information overload, the overexcitation, and the dopamine overabundance. And by doing so, it's bringing the brain back to a normal state of functioning. And this is like one of the most commonly used medications. Examples are haloperidol, risperidone, Abilify, like aripiprazole, and you name it. One thing, just like as a fun fact, we said dopamine is also responsible for movements. So what happens if you block now receptors for dopamine, which are also responsible for movements? Well, some people have difficulties with movements. And this is, very expected given the function of dopamine in the brain. And now I want to hand over to Dessa, who gives us an actual patient story from one of her patients, which we will discuss tonight.
Thank you, Rick. So switching gears a little bit, now that all of you, kind of have learned the basics of psychosis and the basics of how the receptors work in the brain, and also some of the medications and how we use the medications for psychosis. I did want to focus this part of, our workshop tonight on the social aspects, of psychosis. So what happens socially, and, so kind of like looking at it from a holistic view and not just like seeing it as a disease or like how the symptoms are presenting. For me, this, this is an actual patient story. So this is a patient that I followed from inpatient unit all the way to my outpatient clinic right now. And most of the things that I will be talking about in the story are focused on, the psychosocial rehabilitation versus what happens to their social life after, the psychosis is kind of like over, they're out of the acute phase of psychosis and now they're in the chronic stage. So this is, a case of a 32-year-old African-American male who was diagnosed with schizophrenia right when he was, in his when he was 21 or 22. And right now he is on a long-acting injectable. The long-acting injectable is an antipsychotic, Haldol. We will talk a little bit more about the medications and how they work later on. But the long-acting injectables are kind of very similar to the oral medications, but they are usually given, once a month, or sometimes they're given every 3 months. So the patients do not have to take a medication every day, and then they just get a injection, in one of their bigger muscles, and the medicine is slowly released from that injection throughout that period of time. So it's good medication in terms of compliance. People who cannot take medication every day, or patients who are non-compliant with the medication, it's a good one for them. So coming back to the case, the patient was on the Haldol long-acting injectable. I saw him in the outpatient clinic because he was establishing care with me. So he told me that he had his first psychotic episode when he was 21. He was hospitalized around that time. He was a freshman in college around that time. So after he was hospitalized, he was discharged, he went back home, and then kind of like he tried to go back to his regular life where he went back to school. While he was camping with some of his friends, he forgot to take his medications. It's not easy to take medications every day, especially when you start feeling better. Patients often feel now that they're better, they probably do not need medications anymore. And also it's easier for a 21, 22-year-old, I think, to forget taking medications. I don't think it's easier for anyone to remember taking medications every day. So he forgot taking his medications, and then he had an episode of psychosis while he was on the trip. Now, during that episode, he became really aggressive, with his roommates or his other colleagues who were there. Because he was so aggressive, he was hospitalized again. And this time he was hospitalized for a longer period of time, because apparently in the hospital, he was aggressive and he was psychotic for a longer period as compared to his first psychotic episode. He was then discharged from the hospital after he was stable. Because this was a longer hospitalization, by the time he was discharged, he had lost his spot in the school. So, he had no way of going back to school. So he went back to home, stayed with his family, but he was pretty much, at his home. At 21, 22 years old, they usually have their friends when they go to school, right? That's how they socially interact with other people. Now, when he was at home, he kind of like lost many of his friends, and he also lost some of his other friends because he was pretty aggressive, with some of his peers. So obviously there is a stigma that, should I be a friend of this person who was so aggressive? Would he hit me again if I'm his friend? And what if he goes into psychosis? Would I be safe with him? So he lost all of his friends basically. He has 2 younger brothers. While he was living with his parents, he had another psychotic break. He was pretty aggressive with one of his younger brothers. He took a knife. He attempted to kill his younger brother. As Rick was mentioning, one of the symptoms of psychosis is delusions. So he was delusional. And then he had a belief that his brother was possessed by evil. He was again hospitalized, and this time he was hospitalized in a state hospital. So state hospitals, every state kind of like has 2 or 3 big state hospitals, which have more resources for patients, and patients who are chronically sick or who get sick more often and cannot be managed in the community hospitals, they go to state hospitals because they have better resources. So he was in the state hospital this time, and he was stabilized there on medications, and then he was discharged on this long-acting injectable because he has these 3 episodes of psychosis which required hospitalization, and at least a couple of them were those when he was not taking medications. So now, he has had multiple episodes where he was aggressive. People were scared of him to the point that his own parents refused to take him home. So he was homed in a group home when he was discharged. When I saw him in the clinic, he was, he did not have a job. He did not go back to school. His parents would once in a while meet him, but they would try to keep a distance from him. They would not let his younger brothers meet him. They would only let them call him and talk to him on the phone. He did not had many relationships in his life right now. He has never married. He was not dating, no children. Financially, he was living on Social Security, and then his parents would also help him. And then he was telling me that he was looking for a job, but my question was like, what kind of job, and how are we going to help him reach there? And is it really possible in the society that we are currently in? Can you? Oh, so this is kind of like, I would say that this is kind of like the history of, or the time durations in the person's life when they go through psychosis. What are the stages that they go through? So, through research and also by observing people who have had psychotic breaks, it has been noted that some of their symptoms, especially like symptoms around withdrawal, and withdrawal is like when they're socially isolated, or they're a little bit, they're not as interactive as other people. They don't have as many friends, or they look a little bit depressed. So some of these symptoms, which are kind of like negative symptoms, they usually start before the positive symptoms, arise, the positive symptoms of hallucinations and delusions. And these symptoms of the kind of like the withdrawal and social isolation, they last for many years before they have their first psychotic break. So right around, when they have their psychotic break between 20 to 30 years or 35 years, these are the most common and peak years if a person has a psychotic break secondary to schizophrenia or schizoaffective disorder, which are kind of like, as Rick was saying, the non-organic causes when there is no pathological reason behind that. These psychotic symptoms, most often they arise during that age. And after that, this is an interesting slide because it's telling us that the people who do develop the psychotic symptoms, it's not like the psychotic symptoms completely go away and then now they are completely stable and they're back to how, back to how our society thinks normal is, right? Some of their symptoms, they still stay, even if they recover from psychotic symptoms. Not everyone does completely recover. Sometimes people have chronic hallucinations, but they know that the hallucinations are not real. Sometimes people have chronic delusions, that the delusions stay for forever. Sometimes they know they're not real. Sometimes they never know they're real. Many times, even if the positive symptoms do get resolved, the negative symptoms like isolation, not being around family members, not marrying, not having kids, and not finding a job and staying at home by themselves, these symptoms often stay behind. And it's not 100% confirmed that whether the people who have chronic schizophrenia, they are always like this, more I would say like maybe like in layman terms introvert, but not because of their illness. I think that there is also an element of how society treats the people who have schizophrenia, because they don't have a job, they don't have friends. So, you know, they know that, you know, they also kind of like get the idea of maybe I'm not safe around people. So they also don't feel very comfortable engaging in new relationships or going outside, being extrovert, doing social things. Next, please. Thank you. So here we'll take our first breakout, and then you'll get 10 minutes in your breakout room to discuss among each other and, you know, kind of like brainstorm on some of the ideas. And then your kind of like topic of discussion would be, what are some of the challenges that might affect this individual in the community? We are talking about the individual who has psychosis or has had psychosis before, and, you know, has been hospitalization and now is out of the hospital and is in the community. So what are some of the struggles or challenges that this person would have in the community? And if you can think, you know, more holistically, and also name the relevant stakeholders, I think this will be like a very interesting discussion.
And to that's also a good clue what holistically means in this context, right? She was telling you she's not only concerned about medicine, but what we do in psychiatry often is called a biopsychosocial model of care. So yes, we do cause and care about medicine, but we also care about the psychosocial stressors, the psychosocial consequences. And I think Hudasa's slide already gave you like a lot of like indicators, like what some of the issues might be. So you can discuss them, you can come up with new ones, and like, you know, who, and in terms of the stakeholders, like who would be the stakeholders, you know, who would be involved in the decision-making process, right? If someone cannot go back to school because they have psychosis, then who are the stakeholders in charge of making this decision, right? And like all kinds of like challenges you can imagine. And Tudessa and I will just like come into the room just to see how things go. Don't feel intruded. You just listen, and we will see you in the breakout rooms and back in 10 minutes here in the main room. So why don't we just like take a few minutes, 5 minutes or so, to just collect some of the challenges and solutions you guys have identified, if you started talking about solutions. But what are some of the challenges someone with a mental illness, someone with a psychosis, diagnosis of psychosis might face in their daily life?
Can I answer?
Absolutely.
I think working and finding a job, it could be very difficult.
Yeah.
Navigating the stigma surrounding a diagnosis in social situations with like family and friends, or even with employers.
Yeah. All the people who can support them, right? Like who else would they have if not family, friends, employers, all the people which are relevant, like people to someone. When they stigmatize them, who's left? What else?
I think the lingering concern that if you, oh, sorry.
Oh, go ahead.
Okay, so the lingering concern that that if you had a psychotic break once, it could happen again at any time due to factors outside of your control.
I was going to say that another factor could be how mental illness is portrayed today in media.
Yeah. What else?
Just a lack of who they can trust, you know, lack of trust.
What else? Think about some of your daily activities from getting up to going to bed. What are some of the things you can do without any issues, without thinking about the, having these issues for granted, which people with psychosis might not be able to do.
Navigate.
Parent meals,
I'm sorry?
cooking, bake, taking care of themselves.
Yeah, right.
Yeah,
Safe.
their hygiene, yeah,
Hygiene.
taking care of their hygiene.
Yeah. And then,
Transportation.
yeah, transportation. And then the issue, it's kind of like starts now being an issue. If you cannot take care of your personal hygiene, then people might just don't want to hang out with you, right? And then there's the stigma of people who don't have a nice personal hygiene, which they, and so on.
Right.
What else?
How about managing relationships and friendships?
Yeah.
Money, handling their own personal finances.
Yeah. Which is important, right? To get medication, to get insurance, to pay for hospital visits.
Yes.
Yes.
You said stress?
Yes.
Yeah.
Rick, somebody in one of the breakout rooms, brought up a very, I would say, like an interesting point was their interaction with the legal system.
Yeah.
Because so many people who have psychosis, they are in jails and they are in prisons, and those are not the right places for them.
Mm-hmm. Okay, great. What else?
They're at high risk of homelessness.
Yeah. I just add one, being able to take care of medical needs. Someone with a mental disorder who has like cancer or hypertension, diabetes, is this person able to go and see a doctor with all these challenges you kind of just talked about? And there's a reason why people with schizophrenia and psychosis die about 20 years earlier than the average person. And this is partly because they cannot take care of themselves for whatever reason, but including the fact that they can just not take care of the medical needs, in addition to the fact that a lot of people with psychosis also smoke, which puts them at risk for many other diseases, right? I think this list is not exhaustive, but it's a good way of starting to understand what challenges people with mental illness, in particular with psychosis, go through. And we will come back to this in a little bit later tonight. But for now, I think we were hoping to take a quick break. And while you're on your break, I think we can meet back at 8:05. But while you're on your break, we want you to go to Menti, go to menti.com and enter the access code, the numbers you see down here. Alternatively, if you have an iPhone, you can just scan the QR code and also go to Menti. And we want you to answer the following question. What biases do you expect in diagnosing and treating patients of color with psychosis? And then
Rick, we cannot see the next slide.
Oh, it's stopped again. Give me 1 second. How about now?
Now it's good.
Oh, perfect. And the question again is, what biases do you expect in diagnosing and treating patients of color with psychosis? And you can think about this a little bit, take a break. But while you take a break, just scan the QR code or go to menti.com, enter the code, and put in your answers. And after your break, we will look what you guys thought about, okay? Enjoy your break. All right, are we back?
Yeah, we're back.
That's great. All right, so let's look at some of the things you guys said. And as you can see, they're also moving upwards, and you can read it on yourself. There's significant differences in resources and treatments for different groups. Yeah. Lack of social support, lack of trust with providers. Absolutely. That's something we're going to talk about next week. Protested is dangerous. Yeah. People often get a label like this person is of color, so he's dangerous, he or she or they. They will be violent. Yeah, exactly. Not taking their symptoms seriously. Yeah. The crazy black lady. Underdiagnosing people. Psychosis is more mistaken for aggression. Absolutely. Lack of access to the healthcare system. Belief systems that are different, but which are just, sometimes unknown to like providers, which can compromise patient care. Ignoring the cultural context in diagnosing. Yeah, you guys are very much on spot. I give you like 1 more minute to read some of these answers, and then we go back to the PowerPoint.
This is another one, implicit expectations that they're on other drugs or that they won't take their medications. That's also another common one.
Yeah. All right. Well, you guys were really on spot, and we were trying to summarize some of the research in this field, and I'm handing it over to Vanessa.
Yeah. So it's I think that whatever you guys whatever comments you made in the Menti, they are kind of like spot on. And it seems like that these were probably more observations, or you probably had some studies or read some books or observed things in your community. But similarly, researchers, they also noticed these things going on. And then people, decided to see whether this was true or not. So maybe we can go to next slide.
Yeah.
So, there were a few researches that were done to see what were the health consequences of racial bias. Now, first of all, the racial bias, it means that if you provide different standard of care to the patients depending on their race, whether the race is Black, white, Latino, non-Latino, other minority races. We will provide references for these in the end, but we kind of summarized and took out important learning points from those researches. So there was one research where they found that Black patients are more likely to be diagnosed with psychotic disorders as compared to non-Latino whites. There was the perception that the greater illness severity in Black compared to white patients, it led to higher doses of antipsychotic prescription. So it basically, they're saying that the patients who are Black, they would present with one symptom that has more severity, as if that the patient who was white would also present with the same symptom, would not have that much of a severity. So they were being given higher doses of antipsychotics, and then the antipsychotics, obviously they come with their own side effects if you go at a very high dose. And then also patients who were Black, they were less likely to be treated with clozapine. They were less likely to receive, electroconvulsive therapy. That is not a medication therapy. It's basically, it's basically, we call it, like in layman terms, shock therapy. It's basically when you put electrodes on the brain and then you kind of like give seizure through those electrodes. And it's also an evidence-based therapy and has been known to be very effective for people who have psychosis. The other things were that, patients who are Black, they are more likely to be involuntarily committed for the treatment. Patients who are non-white, this is basically, they found that at Connecticut State Hospital, the patients who were non-white, they were restrained 4 times as often as the white patients, because of the assumption that the patient, this certain patient would be more aggressive as compared to a patient who was from a different race. Also, they saw similar things in children as well. So children and adolescents who were from the minority groups, they were more likely to undergo restraints as well as seclusion. Next slide, please. So I think that some of you kind of like alluded to the misdiagnosis in the Mentee. I think somebody said that the symptoms would not be taken seriously, or the symptoms would be, would be like that this symptom is probably related to something else and it's not psychosis. So it's similar. So clinicians could have their own bias. The bias could be because of what experience they have in the community. The bias could also be the place that they work in. What is the culture in that place? What kind of patients do they usually serve in that place? How many patients do they serve? They usually present with psychosis. Their own experience previously with a patient, for example, in an emergency room who was really aggressive, but the patient was, a person of color. So their own experiences too. All of these things, they affect the clinician's bias into diagnosing. Can we go next slide?
If I just may add like one interesting and disturbing fact. I told you I worked in Ghana and Kenya, and some of the psychiatrists, some of the colonial psychiatrists, their readings at the end of the 19th century and beginning of the 20th century literally said the brain of people of color is too primitive to actually develop depression. And this is why up to date, we see there's a lot of like misdiagnosing of depression as psychosis. And we know there's about like what we know across cultures, there should be like about 1% of people should have schizophrenia. And there's like between 15 to 20 to 25% of depression. But in Ghana and Kenya, where I work, it's the opposite. We see like 30%, 40% of the patients have psychosis, and only like 5% or 10% of the people have depression. So a lot of like these writing, these ideas, the mistrust in the system are still ingrained to an extent where people are still misdiagnosed up to date. And that's not only Ghana and Kenya, but here in the US as well.
Yeah, I think it's a global phenomena, the misdiagnosis and the bias around, around racial, different races. It's a global phenomena. And then the other thing is, while you were mentioning that, I was remembering the drug-induced psychosis, right? And somebody was talking about drugs as well. So yeah, there is often a misperception that this person came in with psychosis, so they must be using drugs, and then it's the drugs, not the psychosis. That's why they are behaving in that certain way. It's kind of like the same. The slide is kind of like more of a continuum of what we were talking about earlier. That people who have more positive symptoms, they would be judged as these positive symptoms are chronic, they are persistent, kind of like, it would be considered that, oh, this person is always delusional, oh, this person always has auditory hallucinations. So, why do we treat it? Since they always have this and it's not causing much functional changes. And then this is obviously more enhanced, I would say, in the racial different minority races with Black population. A white person who has, very good support system, or their family are very engaged, they would be like, oh no, you really need to treat this. This is not something new. However, a person who is homeless, a person who doesn't have family, a person who has been coming to the hospital multiple times is more likely to be misjudged and more likely to be called that this person was probably, oh, I got muted. Can you hear me?
Yeah.
Okay. So the other thing is also negative symptoms too, right? If a person comes with more, symptoms that look like depression or issues with communication, sometimes clinicians don't know the community, the person who is, who has never lived in an area where the certain racial population lives might not know what is the culture. And then if they hear certain words, they would be like, oh, I don't know whether this is, the rational thing to say or not, because, that the whole idea of psychosis is that the person becomes psychotic and they lose their connection with the reality. But different reality for different people could be different. So if the clinician does not has enough cultural appropriate knowledge, there is always, an area where they can say that this does not look rational to me, however that could be.
A question.
Yeah.
Yeah, I have a question. Did I say your name Honduras? Is it correct? If it's so, I'm sorry if I mispronounce your name, but you talked about the 32 male who had difficulty of getting a job, and he lost his friends and he lost his university life. So does it help like developing a hobby with the therapy of that patient, or patient who have mental illness in general?
What do you mean by developing the hobby of therapy? Can you elaborate that further?
Like for example, like maybe that person, he couldn't find a job, so maybe trying to write or paint or trying to design like a app or something. Maybe that would help that person to find a job or to make them feel positive.
Yeah, that those are great ideas, and they're in certain state hospitals. They do incorporate these kinds of rehabilitation kind of like workshops or things for them to learn, where they draw, where they paint, where they learn. Sometimes they learn music, they learn singing. So they kind of like learn these. Sometimes they learn gardening, so they kind of like learn these other skills that they can still use, like kind of like handyman skills that they can still use when they go out in the community. So yeah, a lot of state hospitals do that. There are a lot of programs, rehab programs in the outpatient settings where these workshops are used. The question again is, for how long did this person who is homeless, who doesn't has money to buy medications, who cannot go to the doctors, they don't have transport, how long and they can engage in these kinds of workshops, or they can get these other kinds of jobs. That's always questionable. So in my experience so far, but I have seen people who have like chronic psychotic disorders. They do try to, go ahead, step forward, try to do something better, and then they have another psychotic episode and everything kind of like crumbles down. So it's very, very difficult, very hard to rehabilitate them unless we do change what we are doing right now. And then, obviously we are not doing everything right at this point because we are not helping everyone. That's a great thought though. Anybody has any more questions?
So what is something that you can do for someone who is like the person in the case study, who's going in and out of, basically struggling with his mental health and he can't really find the resources to help and has schizophrenia?
Yeah, it's a struggle, right? It's a struggle that we are all facing, and then we're all trying to do our best at the very level or the very limits that we can. Like as providers, our hands are bound, we have very limited resources for these people. I feel like it has to come from the top, and we basically have to be advocates for the people who who are psychotic, who have chronic persistent mental illness, and create awareness in our society, help people understand that, people who have chronic persistent disorder, if they're taking their medications, they might not have a psychotic episode and you can give them a job, right? So it's all of us and it comes from the top. So there has to be like a lot of, I would say, like changes and alterations in our community. especially I would say in the top in the legislature, and then all of us obviously contribute to that as well. And some of you are already doing it here, learning about it.
Thank you.
Sure. So we are going through the medications. Do you skip some of the slides, Rick?
I was just like hoping people, while we talk, like people can read, but I'm more than happy to go back.
That's okay. These are all studies and they can always look through the references.
Yeah, we will send out the PowerPoint.
Yeah. So, these set of slides are basically related to medications and how do we see some of the biases in how the medications are prescribed to patients of different races. And then the studies were kind of like, the summarization is that there were studies that they found that the people of color, they were not being prescribed clozapine as they were prescribed other typical antipsychotics. Now the typical antipsychotics, they have more side effects as compared to, I wouldn't say like as compared to clozapine, but as compared to other antipsychotics. Clozapine is a tricky drug because it does have side effects, but requires a lot of monitoring. It requires multiple labs. It requires, for the first month or so, it requires labs every week. And after that, it requires labs every month for at least a year, is my understanding. So people who are on clozapine, they would need to see their physician. They would need to have those lab draws. And if you have a presumption that, my patient who is Black, they don't have a provider, they are not going to see a provider, they're less likely to get clozapine as compared to another patient who is white, who has good support in the community. They still have a job. Their employers are really nice to them. So you will be like, yeah, I know that this person would have labs, so he's an easier person to give clozapine to. So they found like, in reality, what was happening is patients who were of color, they were getting less clozapine. They were getting higher amounts of the typical antipsychotics to treat their psychosis, and they were developing more side effects. Similar to that, ECT is another tricky treatment because it's not medication. ECT is basically, ECT is basically you provide the electrodes on the brain and then you give the seizure to the person. When you give the seizure, it affects on certain parts of your brain where it helps with the psychosis component. So we will not go in the details of what areas. These are amygdala and hippocampus, and you can read more about that. But the idea behind that is that ECT is very effective. It's faster than the medications. It's not needed on an everyday basis. Downside to that is that ECT, it's people who are on ECT, they require ECT at least 3 times a week for the first few months. And then after that, they do require ECT on an ongoing basis. And it's expensive. Not everybody's insurance covers it. Sometimes people have to stay in the post-op area for a long time. So again, you need a lot of resources. You need people who are close to you. You need somebody to drive you. You need somebody to take you to the ECT department so that you can get the ECT. So, when people consider all of these things, especially clinicians too, I would say, we are all to be blamed. We do consider these things, that whether our patient would be able to afford it, whether the patient would be able to come for the appointments. Would there be somebody who would be watching our patient once they go to the home? And all of these reasons, and along with our presumptions on, my patient who was Black 10 years ago, I treated them, they did not respond to ECT. So why should I give them ECT again? So all of these perceptions, they lead to, this very effective provision, which is ECT. It does not go to everyone in the same way. It goes to more towards the privileged people in our society as compared to people of color and people from minority.
And to that, we have heard about, like, from some of the participants, that trust in the system is an issue as well. So maybe you can briefly share, how, if you had any experiences, especially in the context of, there's like so much we can do what we prescribe, but sometimes patients, even if you prescribe them medication, they wouldn't even want to take it because of like, the mistrust in the system, and they don't trust you as a provider, or they think they don't need medication, but they just, need other modalities of treatment, including like praying, including going to religious institutions and these kind of things. So I don't know if you have like particular thought about this.
Yeah, absolutely. I think trust is first of all, trust is very important when you develop a relationship with the patient, right? If the patient does not trust you, it's highly unlikely that the patient is going to take their medication. They will not take the medication if they don't trust you. And now the patients who have gone through, such a difficult life, like take an example of this case story that we were talking about, who has had such a difficult time, such a difficult life. They have been hospitalized multiple times. And just think about it, if they were aggressive in the hospital, they would have gotten restraints, they would be in seclusion, they would be given forced medications. Now, how can they trust a provider, right? There was one provider who did all of that to them, and now they're going to another provider. So how much difficult it would be for them to trust a provider. And then why would they take a medication if they don't trust you? So yeah, it's very, very, unfortunately, it's a very common thing. And unfortunately, there's very limited that we can do about it. It's a patient's decision if they don't want to take medications. You cannot force medications on them. And then, there are always these kind of like discussions around risks and benefits, right? If your patient does not want medications, they want electroconvulsive therapy. And then you are like, yeah, I do think that ECT would work better for you rather than medications. But, you are a patient that cannot afford ECT. You don't have insurance. I don't know how this is going to work, right? Your hands are now tied. So yeah, there's so much you want to do for the patients, but they're always, I wouldn't say always, let me take it back, but there are times when your hands are tied, and even if the patient wants something and the patient knows that this is a better treatment strategy, you cannot do that because of how our community is like, how the biases inequities that we have here.
And I think to some extent, I'm also bringing this up because we as providers will never hear patient concerns. Because if we ask patients, do you take your medication as prescribed? They almost always say yes. There are a few patients who are just honest and say no, because I don't know what I was taking it for. I don't trust you. I think no, it has too many side effects. And that's great for us because we learn and we can adjust the medications. But you will be at a position as a mental health advocate to have an honest conversation with your patients, and you will have the opportunity to follow up with them and say, well, do you take your medications? Okay, great. Why do you take it? And if they don't take it, well, why don't you take it? Do you feel comfortable telling your doctor? And if they don't feel comfortable, you will actually be able to work with them on like making them more comfortable telling their providers, because only then can this like relationship building and this trust building happen, and also a good care of the patient. And so you will be in a very, very nice position, also very challenging. So let me just move forward to treatment locations. We already heard from Odessa, like patients receive less ideal medications. They don't receive electroconvulsive therapy as often as other people do. Where are people actually treated with psychosis? We know that compared to the white counterparts, people of color are more often treated in the emergency department, which is an issue because the emergency department by no means has equal resources compared to like a state hospital or compared to like a psychiatry, inpatient psychiatry unit. The next issue is that people of color oftentimes don't have access to intensive care management teams. Some of you might be familiar with the idea that there's an inpatient team, and once patients leave the hospital, sometimes they require community support in the form of what we call an ACT team, for example, like an assertive community team. And they will come and help you with your employment, with medication, with transportation sometimes. They will get to the pharmacy with you and all these kind of things. But if people of color don't have access to these resources, then it's only making the status quo worse. Other things I want to highlight in the context of treatment, location, and you guys mentioned already, so you're way on top of it. But I want to stress the idea of de-institutionalizing mental health care. Back in the 1950s, 1960s, the US government, the federal US government was saying, well, let's close down all our, or most of our state hospitals, and let's get these people into the communities where we can take care of them. The reality is that these people have never been taken care of, because as much as there was the pressure to close down federal systems and run hospitals, the community aspect of mental health care was never really developed to the same extent. And some of it led to the idea, or to the fact, that patients didn't end up at the hospital anymore, but at other state or federal institutions, including prisons and including jails. And this is like this little cartoon over here, where you can basically see, as of today, there are 3 times as many people with mental health needs in jails and in prisons than in hospitals where they should be at the first place. And of course, it's no secret that this number is disproportionately affecting people of color with mental disorders. The other thing which you guys have mentioned, and I promise we did do our slides before we came for the talk tonight, but the other thing is like homelessness and mental health, which is a vicious cycle. I was actually just posting, some of you might have heard about Maslow's pyramid of needs here. And the idea is, if you have a mental disorder, you can take care of it if all your basic needs are taken care of. If you have food, if you have water, if you have something to eat, and like rest and accommodation to stay, then the next step is you can also start to think about your health and your mental health. But as long as these basic needs are not met, you will never be able to really think about your mental health or your health care. And the matter of fact is that a lot of people, like 1/4 to 1/3 of those who are homeless, have a serious mental illness. It can be schizophrenia, it can be a mood disorder called bipolar disorder, it can be severe depression, and the proportion is actually growing. A lot of people with mental illness, even the people here who are at the inpatient unit, are sometimes forced out into the communities and to homeless shelters because we cannot offer them better alternatives. Homeless shelters themselves come with their own challenges, right? No privacy, sometimes no people to talk to, no support system. Sometimes they're dirty. Sometimes there's like crime going on in homeless shelters. And by no means am I trying to generalize. There are homeless shelters which are really ambitious and they are trying to work with patients. But the reality is that some homeless shelters also don't actually help patients with mental disorders. The system and some of the homeless shelters are just not built to help them. The other thing is, like, what do you do with patients who want housing? Well, the reality is there are a lot of studies showing that if you're a landlord and you rent out property or apartments, you're less likely to give it to patients of colors, like to people of color at the first place, but you're even less likely to give it to people of color with a mental disorder, which basically, prevents these people from having an apartment and having like the ability to be safe and to have their own apartment. And then the other thing is like, well, if you're homeless, well, what is the effect on transportation? Can you afford transportation? Can you go and can you pay for your care? What about the stigma, right? I mean, homelessness itself comes with a stigma. What about communicating? Oftentimes people who are homeless don't have access to a cell phone and all these kind of things. So to summarize, people of color are more likely to be diagnosed with a psychotic disorder compared to like any other disorder, such as depression, like a mood disorder. They receive more typical antipsychotics and depot antipsychotics, which is like injections, long-term injections. They're less likely to receive one of the gold standards in schizophrenia and psychosis, clozapine. They're less likely to receive ECT. So in summary, they're less likely to receive effective treatments. They're less likely to be treated in the appropriate treatment setting, which in fact contributes to like chronic symptoms, chronic impairment, and oftentimes, premature death and these kind of things. Now, we want to use this opportunity to respond to some of your questions. I am not following the chat right now, but I saw there were a few questions popping up or a few comments, which I cannot see right now, but maybe Odessa can help me identify some of the things which came up.
We don't have any more questions right now in the chat.
Perfect. All right. So then let's go into a breakout room again. We can make it Probably you can make it 7 minutes, just for the sake of time to get you guys out on time. And based on our discussion and on your previous breakout room, we want you guys to talk about now, what are some of the things you can do as a mental health advocate, knowing the challenges, knowing the biases, knowing the disparities, knowing, all the facts and things we talked about tonight. What can you do to overcome some of these challenges and some of these barriers? And you can think about, existing systems. Well, how can we better utilize existing systems? But you can also think about how you can create new systems or like new things or new ways of advocacy. And you can be creative. There's no right or wrong answer. We just want you to start brainstorming. And we know 7 minutes is not enough, but we just want you to get started. Why don't we take a few minutes again to brainstorm some of the ideas you guys had in your groups? I don't know if you can copy and paste it. Like, I think you can all see this. What they're supposed to. What else? What did you guys come up with? What are some of the solutions you thought about?
Can I speak?
Of course.
So I think we can use social media as a platform to spread awareness and reach out to more people about mental health and trying to make awareness and maybe like workshops free with some of the advocate.
Love it. Yeah.
Yeah.
And the good news is you don't have to get started. There are a lot of organizations, NGOs on social media accounts already, including NAMI, including Mental Health First Aid, and you name it. So you can start following them, sharing their content, do your own posts, whatever you want. But sometimes it's hard to get started, but you don't need to reinvent the wheel.
Because my university is doing the same. They always post on social media like mental health awareness, workshops, how to deal with stress, trauma, and so many other things. And they're free.
Great. All right, what else?
Jessica is saying the church needs to be up on awareness of mental health and serve these precious ones who need our help.
Okay, yeah. What else?
I would say schools as well. We can start educating, from the very start, like from elementary classes about mental health and how it looks like.
That takes me to NAMI that has 13 different programs from peer support.
I think you're muted. We only heard the beginning of what you said, and then you muted yourself.
Yeah, I think she was saying that NAMI has a lot of other organizations.
Yeah, I did. I'm sorry. NAMI has 13 different programs where they start from the individual for peer-to-peer to family support to community support. There you can learn all of some of the things that we're learning tonight. I've been a part of it, even to the point of going to the community, working on public policy, making sure that the healthcare determinants are addressed. So when we do that, we do have people we can constantly be in educating and then taking the responsibility of helping those lives see the importance of treatment and quality and care.
Love it. I love it. Yeah, that's all great. Let me add like two things. one of my favorites. Oftentimes we talk about people with mental health conditions, but we don't ask them what they want. We don't ask them what they feel. We don't ask them what they have as a solution, right? And then there's this like saying, nothing about us without us. So you might ask yourself, well, how can I make a difference on a system level? It is so hard, right? I mean, yes, we can talk about awareness creation. We can talk about, like, you know, listening to people. But if you, as a mental health advocate, realize how much power you have, if you empower people, not all, but a lot of social movements actually depend on hearing from those who are marginalized, those who are discriminated against. So you can empower them. And then this is like my second point, like you as an advocate, you have a lot of power. Like, don't underestimate how much it is worth for patients to be listened to, how much it is worth for patients to spend some minutes with someone who's interested in hearing their stories, who is curious, who is genuinely interested, and who is not just like seeing them as a medical provider, but as a human being. So don't underestimate these tools you have. Public policy. You know, there are tangible public policy options. I don't expect you to read this. It's just like, you know, to show that there are a lot of like thoughts about public policy already. And let me start sharing my screen again. Can you guys see my screen?
Yes.
Perfect. So public policy, right? I mean, the idea of, like, you know, who needs to come together. It is not only the work of the Department of Health, because as you rightly pointed out, the police department is involved. The educational department is involved. The agriculture and business department is involved. The finance department is involved. They need to start working together. And one way of making yourself heard is by reaching out to your House of Representatives or Senate members. One way of making yourself heard is to do awareness creation and to meet with community members, to go into communities and listen to what they have to say. Another way is like to actually just, you know, think about microaffirmations or affirmations. You know, a lot of, like, oftentimes we talk about microaggressions, like the subtle things we say, the subtle things we do, where we give people the feeling of like, you are worth less than I am. But we can also do the opposite. We can have like micro-affirmations where we actually support people. It is sometimes only the way we talk or the way what we say and how we say it. The question is like, how can I hear from you? How can I learn from you, right? I'm here to treat you, but I want to learn from you. It's a mutual beneficial partnership we are building. I need to put myself into someone else's shoe. Who am I to say, well, this doesn't make sense to me, right? If you tell me mental disorders don't need to be treated with medication, but I need to pray more, who am I to say this is wrong? I want to listen to you, and I want to know why you say this. I want to know how this is affecting you. And I want to know what else is in your mind so we can talk about this. And then there's this big thing about design thinking, which I just want to introduce briefly tonight, because we will talk in way more detail about this next week. Design thinking is one of the ideas of, we know why we need to act now. And I guess like part of why we need to act, this is the reason you guys all signed up for. We, to some extent, know what we need to do. We came up with solutions, but oftentimes the question, and this is something which came up in my breakout room, is like, how do we do this? How do we make ourselves heard? How do we have an impact? And design thinking goes back to the idea, you know, when we work with communities, how do we make sure we hear from them? How can we come up with new solutions? How can we come up with solutions which have been proposed elsewhere, but tailor them to our communities we are serving and we are advocating for? And this is something we will look into next week in more detail. For now, we want to close the session with giving the opportunity to you to ask any questions you have or raise any concerns, make any comments, talk about things, you know, we should have talked about, like, or things you were, you know, feeling you want to know more about. This is your time.
Well, the young lady, Jennifer, who talked about the awareness of the church, a lot of times that's the vehicle for going with African-American people and being a partner there, because the first responder for a lot of African-American communities is the church. Mm-hmm. And when they go to the church, if the church isn't educated, then the people will not trust. So if you have that primary person that comes in and gives the first aid, because that's what I call it, as being able to understand diagnosis, understand medicine, and then understand how can I serve you with a voice of truth, and also say, okay, these are disciplines that you can use that bring you to a holistic perspective, but medicine must be included for this type of disorder. If I treat you for cancer, I'm going to give you chemo. So understanding that cyclochrome or the ECT is a necessary element, then I must set up in the church or in its community some people who will go with that particular individual till they come to the end of the process for good health. I think that that's missing a lot of times. We look for the hospital to do it, but we don't look for the church and its community organization, because it could be a homeowners group.
Yeah.
But they know somebody in their community who's ill. But you have to give that permission or get that buy-in from the from the person who's ill. Because many people have organizations who have cancer. They go to the family, they say, hey, I'll take you for treatment, and stick with them until the process is complete and the person feels healed.
Yeah.
Healing comes in a multitude of ways, but it's again back to the trust. And so we have to bring those trusting boundaries together.
Yeah.
And I think that's just a powerful way to start.
Yeah.
I love what you say for many reasons, but here are my two top reasons. One, I think you're absolutely right. Some of the treatment doesn't even have to take place in the hospital. In fact, if you bring people to the hospital, they will be disappointed because, oftentimes we cannot offer what the community can offer.
Right.
We cannot supplement community with medication, but the community is really the place to heal for people, to recover, to empower. We can only do acute services in the hospital. The second reason why I really love what you just said is because oftentimes people start thinking about this in an ambiguous way, or like in a way where, okay, should I pray and like stick to the community, or should I take medication? It is not the question if you do either or. Oftentimes we need to empower people to go beyond this and say, well, why don't you take medications, but also pray and also have support, feel supported by the communities.
Thank you. I think Duke University also has their hospital where they go into community and congregations to empower people. I remember reading a long time ago as a chaplain how to just go in and be neutral, to be empathetic, to have the gift of presence so that people will understand what healthcare really is. It's not just somewhere you just slide into momentarily, but it's an engaging or long-term relationship where everybody is involved.
You're right, absolutely.
No isolation. You don't just go for a headache and then everything's okay, because the headache may be a symptom of something else.
Yeah, you're right. And ideally what happens is, like some people start this whole movement, like, give churches a role in this whole challenge. But eventually, hopefully, then congregational members will also be able to take over some of it and own the process, right? They stop relying on mental health professionals, but they themselves feel empowered enough to do some of the teaching and some of the awareness creation and some of the outreach and some of the connections. And this really itself creates community, which is so much needed in mental health care.
Wanted to answer Gina. So basically, like people who have non-organic causes because for their psychotic illness, non-organic primarily being like primary psychotic disorder, like schizophrenia, schizoaffective disorder, or psychotic depression or mania with psychosis. These patients usually progress towards a chronic illness, is what we call like chronic persistent mental illness. And these patients are more likely to be seen in an outpatient setting, because in an outpatient setting, you see patients who are more stable, that who you can see in an outpatient setting, and they're not, actively harmful towards themselves or towards others. patients who have an organic, or I would say, you know, there's a pathological cause for their psychosis. For example, if they have a brain lesion, if they recently had a traumatic brain injury, if they have psychosis because of altered mental status, confusion, what we call delirium, or they have, you know, psychosis from any other medical illness that causes delirium. Most of these patients, they usually present in more acute settings, like in the emergency room or in the inpatient medical hospital. Sometimes they would be transferred to inpatient psychiatry as well after their medical illness has been treated. So these patients are mostly treated in the acute, in acute setting. However, once these patients, the prognosis for the patients who have the non-organic causes, like, you know, there is a pathological reason, is better than the patients who have, you know, primary psychotic disorder. So most of the times their psychosis kind of completely resolves in those patients. So these patients could be followed up in the clinic afterwards, but they are usually more stable. So I would say, like, in the end, over the course of like next 5 or 10 years, if a patient develops psychosis, the patients who have psychosis from primary psychotic disorder like schizophrenia, schizoaffective disorder, they are more likely to be seen in clinic.
All right, any last minute, second questions, comments, concerns? But congratulations, Guy, on being on your way to becoming a mental health advocate. I really do think that your work will be very impactful and strong. And I really hope that tonight's presentation was, you know, one small step in your big journey as an advocate. And I wish you well. And so does Sudesa. So we wish you well. And if any questions come up, I will be back next week. And so please let me know. You can email Bruni or any like organizer of these talks before next week's talk, so we can potentially even, you know, prepare material based on your questions.
Yeah, feel free to reach out to layMHadvocates@gmail.com with comments and suggestions. Thanks, everyone. Have a great night.
Thank
Take
you.
care. Good luck. Good night.